Good afternoon, everyone. This is Marlon from the GMU Bioethics Podcast. I'm going to let everyone around the room say who they are. Going this way.
I'm Dewey.
This is Dominic.
And I'm Roxana.
Cool. So today we'll be discussing the ethical implications and complications of medical futility. So just to start with the basics, medical futility can be described as medical interventions or treatments that are unlikely to produce any significant amount of benefit for the patient. It's important to note that when you're talking about medical futility, that the term futile is referred to being specific to the treatment. For example, you wouldn't say something like, treating Bethany longer would be futile. Alongside sounding really harsh and depressing, it would be an incorrect usage of the term. Instead, you say something like, using this specific technique or medication to treat Beth's condition would be a futile treatment because it would not significantly benefit Beth in any way. These determinations are not usually based on speculation, but are rather backed by empirical and statistical evidence. This becomes a controversial topic when it's time to make decisions of when to stop the treatment and what can be done instead. A couple of sticky situations we're going to try to steer away from are cost of treatment and the possibility that a treatment or a lack thereof may be beneficial to dependent family members, the doctors, or insurance companies. We're just doing this just so we don't end up down the rabbit hole of blaming insurance companies and the structure of our medical system, which usually happens a lot when we're doing bioethical or medical discussions. The first segment is going to give us more info on why this can be a touchy topic. Coming up next.
So this is Dominic coming in for topic 1. So who's responsible for making this decision? Is it the physicians, the patient, maybe family members? Well, speaking legally, the treating healthcare physician is responsible for the decision of whether or not to end the treatment or implement a different approach. And the doctors have no obligation to provide treatment that is not beneficial or will not yield a positive result for the patient. So how do doctors even come to this conclusion? Well, it's actually quite complex. Most physicians sum up the quantitative and qualitative aspects of the treatment's futility. Most often, the patient's desired physical effect is in the mind. And, all this means is that they take into account the probability that the intervention will be beneficial and the quality of the benefit it will bring to the patient. And they often consult the patient, colleagues, and family before their decision. However, there is no strict protocol to follow this procedure. So why is this controversial? Well, some people report not being happy with the fact that the healthcare provider gets a sort of dictatorship over what is done and when. And they say it is one-sided, and families of the sick or injured usually provide a lot of backlash as an effect of the abuse of power. So who has the competence to determine the usefulness and the fruitfulness of treatments and care services? This dilemma has remained unresolved because of personal, cultural, and religious values, as well as beliefs coinciding with socioeconomic status that severely affect its perception and interpretation. So I'm going to hand off an example to Dewey.
Okay, so an example of this occurred in 1990 during the decision of the Cruzan versus Director in Missouri. So the patient, Nancy Cruzan, was left in a vegetative state after an automobile accident. She was sustained for several weeks by artificial feedings through an implanted tube. Her parents tried to terminate her life and support system, but the hospital staff refuses to do so without the court approval. There was evidence from her former roommates that if she was ever in a position to not have the ability to take care of herself, she would want to proceed to be taken off of life support. In the end, the Missouri Supreme Court ruled in favor of the state's policy over Cruzan's right to refuse treatment. So the Supreme Court declared that there was insufficient evidence that the patient wanted to the removal of life support and ruled in favor of the state of Missouri.
So going back on what I said before, there are very few protocols that exist for medical treatment, and the course of action is usually left to the doctor's discretion. Some doctors can be more forward with their approach and proposal of what to do, which can sometimes infringe upon the patient's autonomy and rile up the family. These doctors often complain that the requested medical procedures are inappropriate and will yield no real health benefit to the patient. Others will move slowly and work closely with the patient and their loved ones to ensure that all are on the same page, more of an informative model. But this may delay the time that could be used to complete the necessary treatment. A great example in this is the Marsala case. In this case, a woman admitted her mother to an end-of-life care facility to, quote, receive the best possible care. However, the physicians in charge ended up terminating her life support without conducting other various test measures. And it can be noted that the patient was showing signs of still being alive. She was able to blink, squeeze hands, but not speak. This ended the patient's life and sent the family into a state of immense distress. This is only one of the many examples of how the lack of protocol and proper procedures affect both physicians, patient, and the families of the patients. So do you guys have any thoughts on this case?
So in this case, the family transferred the patient to the facility to prolong their life expectancy, meaning that the purpose of the patient being at the facility was because she and her family wanted to live longer. And like you stated, she exemplified that she had the ability to blink and squeeze anyone's hands and all that. Prior to her transfer, she was already on life support at a hospital, and being there, she already told them that she refused to be pulled from life support. So when, of course, the staff decided to terminate her life, it caused emotional distress to her family members because it was a wrongful death. What did the family end up doing? I would assume that they sued the facility for negligence. Were the family informed only after they took off her life support? Was there ever a chance that they could have prevented this action from happening? This case seems to have very little details on exactly what had happened at the facility. And there are plenty of evidence that both the patient and her family wanted to keep her on life support. But exactly how much evidence is needed to present to the facility? It seems that the statements from the patient and the patient's family does not seem worthy enough to the facility or the court system. But this isn't a discussion on what the patient can do to ensure that their demands are followed, but what can be done so that the staff at the hospital and facility will provide proper protocols and procedures.
All right, so next up, we'll be talking with Roxanne about how medical futility affects the patient and what alternative options may be present in the situation that their treatment is deemed medically futile. Coming up next.
So before everything, I want to mention that it's important to note that simply stabilizing or maintaining a patient's sickly condition is also considered futile. So there's no improvement, and therefore it's considered a terminal death for these individuals at this point. In order to get the full picture, we must be able to map out the advantages and disadvantages of medical futility itself. It can be deemed necessary to continue with these interventions when at the request of family members who might be living far from them and they would like to see them for the last time. They might be waiting for an artificial transfer organ to be made available as well. There's also social, cultural, and religious reasons for them. Healthcare professionals might have personal attachments and beliefs, and these professionals also might be afraid to continue with any sort of treatment, so they just may go on with this futile intervention. It can be considered highly inappropriate at times when the futile treatment might cause additional suffering and discomfort for those last few days of life, as it may decrease their quality of care from prolonging a process. It can waste resources, which would put other patients at risk, as they may need more of them. This makes it a lot more risky of a situation when in emergency scenarios. Another way would be that the patient or family may not be able to afford these interventions. It places a financial burden, which could also be a motivating factor in wanting to undergo a process of euthanasia. Now, euthanasia is deemed as a cost-effective procedure. However, there is an extensive debate on whether it is ethical to prolong someone's death against their wishes, as it may be unethical or not, which we're not actually going to talk much about on this podcast. There's also another possible option, such as getting a DNR, which is a do not resuscitate order. It's basically just a doctor's order that orders to not do CPR if a patient stops breathing or if their heart stops beating, but this doesn't include all cases. So as a question, what are some examples that can be deemed as appropriate or inappropriate to continue with medical futile treatment?
So in October of 1992, a baby dubbed as Baby K was born at a hospital with anencephaly. She was initially placed in a ventilator in order to provide respiratory support. The mother was informed that most babies with this condition dies within a few days of birth due to breathing complications and other difficulties. The physician recommended that baby K should only be provided with supportive care like nutrition, hydration, and warmth, and to be aware of the possibility of a DNR order. He explains that the medical treatment will be too aggressive and would serve no palliative purpose. However, the mother did not agree with the physician's recommendations and insisted that baby K should be provided with the medical ventilation when necessary. The hospital thought this was inappropriate and wanted to transfer baby K to another hospital, but the other places refused, so baby K was transferred to a nursing home where she was admitted 3 times to the hospital due to breathing difficulties. The mother's decision to continue with this treatment could be considered inappropriate because the chances of her baby dying within a few days were high.
Now, on the other side of the spectrum, there is the option of palliative care until death. And this type of hospice care proves to be quite successful from the chronically and terminally ill. It prevents and relieves suffering and encourages support for the best possible quality of life for patients and their families, regardless of the stage of the disease or the need for other therapies. For these patients, instead of focusing on the negative parts of their lives like sickness and physical degradation, they're encouraged to pursue emotional and spiritual freedom as well as pain relief. Statistics on hospice care and success include over 65% of patients' pain having been brought to a comfortable level within 48 hours of admission and assessment. However, things like hospitalization, experimental procedures, and every other life-prolonging procedure is not covered by insurance when people go into hospice care, and this is just going to create a bigger financial burden. So to wrap this topic up, I wanted to ask what you guys think if someone refuses to undergo palliative care.
I mean, I think that ties into if the patient can actually speak for themselves. I believe if they're deemed medically fit to speak for themselves, then, we have no right to refuse their offer. But I feel like if they can't speak, we probably should be asking the next of kin. Just because, you can't make a decision without the family's input at the least.
I think it's perfectly acceptable for people to decide that they don't want palliative care if they feel like they want to live out the rest of their lives, doing whatever, vacationing or spending time with family. That's really up to them, and if that's the way that they want to end their life, then that's up to them. So, all right, that's all our time for today. Thank you all for listening and/or sleeping through our podcast. We really enjoyed this material, and we hope you did too. We'd like to shout out Ashlyn for helping out with tech and research initiatives for today's podcast.